these are the detriments like in which spaces the pus accumulation or the infection will spread. For example, if it's a upper tooth, it can go into maxillary sinus, it can go into palatal region, it can go into buccal, vestibular region or buccal space if the roots are lying above the buccinator muscle. Similarly, in the lower tooth, the infection may progress into sublingual spaces if it is above the roots or above the mylohyoid muscle, and if it is below the mylohyoid muscle, it will go into submandibular spaces or submental spaces. Then again, if it is above the buccinator, it will go to vestibular. If it is below the buccinator, it will go to buccal spaces. Again, the dentoalveolar abscess, it can, the major source of the dentoalveolar abscess is the pulp chamber. Mostly it is periapical, but another is the periodontal abscess can also lead to the dentoalveolar abscess. So usually the point from where it will come out, it mostly depend on the thickness of the cortical bone and the position of the tooth. For example, mostly the canine are more, the root tips are buccally, so most of the canine, and they are above the levator anguli. So most of the canine infection lead to the infraorbital infections, and that too on the buccal side. Lateral incisors are more palatally, so most of the lateral incisor infection accumulate at the palatal side. Similarly, in molars, let's say if the roots are smaller and the opening is below the buccinator muscle, then pus formation will lead to the vestibular abscess. But if the roots are longer, then it will directly go into buccal spaces. It is not necessary that once a infection has occurred in the vestibule, it will remain here. It can definitely go to the buccal spaces as well, or maybe into the sinus. So as I mentioned earlier, in lateral incisors and all, where the root tips are more on the palatal side, the abscess comes at palatal end. So these are the regions which are showing infection from which tooth will go where. It all depends on the anatomy. We have to be careful with the anatomy and the vital structure. Most of the maxillofacial infections we have seen, apart from the decay and all, is from the third molar infection. From the third molar. So from the third molar, it can go into deeper spaces like or pterygomandibular spaces or into the buccal space. So facial spaces are very much important for to know like how this for the knowing the spread of maxillofacial infection. Facial planes offer anatomic highways for infection to spread. If we do a surgery, like if we open the skin, first of all we'll see the skin and subcutaneous tissue. Below the skin, we'll find the subcutaneous fat. Then comes the muscles, platysma muscle. If we go deeper, then we'll find these spaces, facial spaces, and the infection why it spreads to the facial spaces because it is quite avascular. Even when we do the infection, we don't find blood in this region. So that's why once the blood is not there, it becomes a favorable point for the bacteria to divide. So also the antibiotic availability in facial spaces is limited due to the poor vascularity. So treatment of facial space infection depends on incision and drainage. Facial spaces are contiguous and infection rapidly spreads from one space to another space. Despite IND, like incision and drainage, the etiologic agent, the tooth must be removed. Like source of the infection must be removed out of the body. See, in maxillofacial region, the source of infection is very, very, very important. Even if you do incision drainage, whatever you do, you have to take out the source of infection, whether it is tooth, whether it is root stem, whether it is any of the foreign bodies is there. So primary mandibular spaces come like submental spaces, and so in submental space, there's a dependent drainage of this spaces performed by placing a horizontal incision in most dependent area of the swelling extraordinarily with a cosmetic scar being the result. And in submandibular spaces, the boundaries are superiorly, it is mylohyoid muscles are there. Inferiorly, the border of mandible is there. Anteriorly, the anterior belly of digastric. Posteriorly, again, the posterior belly of digastric muscle is there. Inferiorly, it is limited with the hyoid bone. And superficially, platysma muscle is there, and layers of deep cervical fascia are there. So here we can see like this is the submental space, and below the mylohyoid muscle is the submandibular space. So usually the infection will, and while the treatment, we have to give a small incision at the lower tip skin at the dependable area. Also, we should not puncture the thinned skin, otherwise skin necrosis will happen. So it should be at the most dependable area, not from where like it is pointed. So we can see a clear cut, like in some mandibular spaces or submental spaces. We can see a clear cut erythema and hyperemia at submandibular region. Again, if we are talking about sublingual space, it's a distinct space, but yes, the point of incision is more or less same. So submandibular and sublingual spaces are surgically distinct, but should be considered as a surgical unit due to proximity and frequent dual involvement in the odontogenic infection. So same here, as we have mentioned, like superiorly there is a geniohyoid muscle, and it is limited by the mylohyoid muscle, and posteriorly again the hyoid bone is there. So we do see, like for submandibular region, we mostly see the swelling extraorally, but at sublingual spaces, the swelling is at the lingual vestibule. In epiglottis infection, we do see the infection in the epiglottis. There will be the difficulty in swallowing. Now comes the buccal space infection, which we do see in most of the cases. And if you have to see, like we do, we it is mostly occurs when the root tips are long and they are beyond the buccinator attachment. So the infection directly gets into the buccal spaces.